Good, it's been
We are
ages.
going live now in 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and we are live.
Alric?
Hi, everyone. Good evening, and welcome to this Posi webinar on the COVID-19 pandemic. I'm sure you have a lot of questions, myths, and misconceptions about this disease. And as we all know, it's quite an evolving situation, even though it's almost 3.5 months since the first case was reported from China. And today we have two very eminent speakers who will share some of their views with us to hopefully clear up some of these doubts and misconceptions that we have. I'd like to introduce our two speakers. Our first one is Dr. Ravindra Mehta. He's a very close colleague and friend of mine right from MBBS days. He's basically a very reputed pulmonologist and critical care specialist working at the Apollo hospitals in Bangalore. He's had a very illustrious career starting from KEM Hospital in Mumbai and then moving on after his post-graduation to the US, where he worked for several years. And he has multiple board certifications in pulmonology, critical care, sleep medicine, and internal medicine. He then came back to India and joined the Apollo hospitals in Bangalore. And welcome, Ravi. We're really happy to have you today. Our other speaker is Dr. Vinay Devraj, who is a consultant infectious disease specialist also at the Apollo Hospitals, Jayanagar, Bangalore. And he will share some of his wisdom and expertise about infection control practices during the time of the COVID pandemic. So Ravi and Vinay, thank you very much for accepting our invitation on behalf of Posi to share your experiences with us. And over to you, Ravi.
Well, thanks, Aldrich, and thanks for calling us here. It's lovely to be in such a horrible situation, trying to tell everybody what is going on. So, what we thought is that we'll go in two sort of phases. I'll go over the COVID-19 basics, how the whole thing started, and cover a lot of areas. Some of these may be very well known to people, and some of these may be new to you. But it builds up the whole background and reinforces what we're talking about. And then Vinay will come in and cover a lot of the infection control and the questions you have on your day-to-day stuff related to that. We have tried to incorporate a good deal of the questions which Albert sent us before. So hopefully that will take care of what was there in the background. And then in time permitting, we'll be happy to answer whatever more we can. So let's start with the original story out here. We're starting with the background completely over here as it started, and it's been, I think, a whirlwind story in the last 3 to 4 months, as we have seen this disease started in December when it started in Wuhan. All of you know that Wuhan became an internationally known city from when we had never heard of it before, and then it just spread like wildfire. Finally, WHO declared this to be a pandemic, and everyone feels it was a little late because we could have marshaled our forces a little earlier. But be as it may, that's been both the delay and the lessons which come out from it. The virus has spread exponentially, has spread no geographic area till date, close to 200 countries, and even cruise ships who got their own particular identity when it came to mentioning the cases on those ships. And world over, healthcare facilities are overwhelmed with the number of cases. I mean, the most developed of countries, and in that includes the USA, UK, France, Spain, Italy, and so many others have been struggling and actually became the epicenter of the disease after China. And it has been described as a catastrophic event of the century because something like this has never been seen since the Spanish flu of 1918 in terms of its ferocity, speed, and the hit it's taken worldwide. So, with this particular background, what is going on in our country, which is the reason we are here and what interests us, and we are in Bangalore, so we always had a component of that. All of us know we're in the midst of a countrywide lockdown. Phase A started, Phase B, which was very logical and predictable, came, and though it surprised some of us, it was in the pipeline for sure. The more important thing is future lockdown release on May 3rd, as is being discussed, and re-lockdown. What is going to happen? Is it going to be partial, complete? A lot of questions. We'll try and get into that. Incidence is still going up, which is very, very expected as per the predictions, epidemiological predictions, which happen in such a pandemic. testing is limited. So whatever you see is probably, only a percentage of what is actually out there. So the actual denominator, which would be in an ideal world, the number of people afflicted is not clear, and it will probably never be clear, as is reflecting the experiences in other parts of the world. The numbers as of today in one of the website sites which we follow is, you can see around 800, 1800 plus cases with around 600 deaths. Maharashtra has become now the leader of the COVID pack at this point. You have around 5K with 2.5K out here in Mumbai itself, and 232 deaths. Delhi is also rapidly picking up with that's rising in Gujarat, sped up over there, unfortunately. Similarly, Rajasthan and Karnataka relatively slowed down. So we in Karnataka and Bangalore are not seeing so much right now. But certainly these states and union territories are speeding up over there. The worrisome part was these cluster areas, and all of you know about them, which are foci of this of the disease, where it's where the disease increased and started to spread, and they've been called hotspots, and the red designation has been given to them. Metros are the main foci, and the initial prediction was that Mumbai, Delhi, Kolkata, Chennai, Bangalore will be the main areas. But this is now varying as the disease spreads with the cluster areas. Bangalore predictions are pretty horrible when we saw them, and each state has tried to predict its own numbers so as to plan its healthcare. So there, if we had planned in Bangalore that we had 0.15% of the population, that was 20K people, out of which around 3,000 would need hospitalization, a huge number, and 1,000 ICU beds. So these were the horrifying numbers which actually set the stage for planning. That was the epidemiological predictions which came from not only India but other parts of the world. So what happened as a result of that? Governments geared up, and my God, they geared up like crazy. And that is where they concentrated on the area they could do first, which is public health and healthcare delivery. And so most after the initial big, huge, massive, and much required step of lockdown, which is both questioned in all directions, but here to stay and has certainly impacted the prevalence so far. The concentration was public health and healthcare delivery. Most of the arrangements, as you would expect, came in the government sector. Something to talk about when you consider India's paradigms, where the ratio of private to government utilization is literally 3:1. There's a paper on that in 2019, but initial all of the reactions have been in the government sector. The struggles have been manpower. Nobody has dealt with such a crisis in such a short amount of time. And then the magic word, the word of the decade, which is personal protective equipment. Everybody knows about that, because understand that we came at the tail end of this whole thing. There was China, then there was Italy, then there was UK, Spain, France, and the United States, and then at the end of the line, we are trying to marshal our resources to keep enough of these equipment, essential equipments. So private sector role has been relegated to second place for now in most cities, except for some states who have tried to take over private hospitals, and a patchy few beds have been reserved in few cities. So this has been the state, and this will keep changing, because certainly the speed at which information is coming in and affliction is happening is plans have to change very quickly. Transmission dynamics, for those of us who want to know how bad it is, already know about it. The average number of people that one infects with the virus is called the R naught, a number which none of us knew before when we had to study all these things. For COVID-19 is 2 to 2.5, which means one infected person can infect 2.5 people. How many of those 2.5 will fall sick and require healthcare is a different issue altogether. This number has been variously touted to be up to 4 and 4.5 also. Comparison numbers, H1N1 2009 was around 1.2 to 1.6. And a lot of us will say that H1N1 was there. We've seen some of SARS. Tuberculosis has the number of close to 5. So why worry so much about this? We'll talk about that. But understand that this has also been accompanied by an epidemic of information. It's been called the infodemic, so to say. And in that infodemic, I think H1N1 plus WhatsApp is equal to COVID-19. And that's how we've been so awfully inundated with information, unable to handle it, and worried even in the healthcare space, that we've really panicked in so many levels, which should not have happened, one feels. So scientific rationale behind social distancing, very nicely put into pictorials, is that if you ignore it, then one person as per the R naught will infect 2.5 people. And then in a span of 30 days, if allowed to move unrestricted, which is pre-social distancing or lockdown, can affect a whole bunch of people. And that was a massive rationale of trying to say, keep humans away from humans. Otherwise, we're going to go in the lines of all those countries, all those developed countries who are unable to handle their own load at this point. So with this background, we'll go through some myths and realities, common misconceptions about COVID-19, which also help to address some of the issues which were brought up. We were hoping to God that we would escape for a multitude of reasons. The first one of which was the hot Indian summer, and as we are sweltering in some of our cities, we thought that this is going to make us better. Well, neither the Indian summer nor the Indian immunity is likely to protect us from COVID-19. It's the reality of the fact there's enough and more data. I'm not going to get into data for every statement, but it is well validated. The immunity part also was mentioned as being something, maybe we have immunity from other coronaviruses. I mean, we're a virus infested country. All of us get afflicted. Maybe that's going to protect us. Turns out there's a lot of work showing that there was a mutation in this coronavirus. So this is not recognized by immune system at this point. So we can't bank on our immunity to protect us. And the same thing, more and more concerning or fearsome. I think I call this data fearsome, because the moment you get your comfort level, somebody will put out something that no, you're not going to be comfortable. That there is the coronavirus is also mutating in some way or the other. So that also may be another issue, and also may be a problem for vaccine targets. But that is something touted and not necessarily categorically proven. Then came the thing that, okay, just like other flu, seasonal flu, H1N1, only older people will be affected above 60, chronic lung and heart disease. Turns out that as it swept from China and went to the other developed world, younger people are getting affected. And even in our population, in Maharashtra statistics, for example, you do have a significant number of young people. So yes, more in the elderly and with comorbidities, but young people are not as immune as we thought. And we'll show you some statistics about that. Then was the whole thing that, okay, at least I need some clinical criteria. We are clinicians. We like to pin down a diagnosis. We like to know that a certain constellation of symptoms is going to help me or any of my pertinent specialty colleagues to close this as a clinical situation. Turns out clinical medicine is taking a backseat when it comes to COVID-19 diagnosis. So even fever, which is so common in all the viral infections, is neither mandatory nor necessary in COVID. And now, literally over time, every system, and I repeat, every system, including gastrointestinal, constitutional, myalgia, and so on, and even neurological, have added to the spectrum of what COVID-19 can be. So now we are stuck, especially in the respiratory cardiology arena, where CHF exacerbation, COPD exacerbation, neurological syndromes, fluid overload with renal failure, your ortho patients who come to us with some dyspnea, atelectasis, everybody is not immune from the clinical syndrome of COVID. So that's become a major problem to deal with at this point. To add to that symptomatology discussion, well, fever incidence was around this number, 70 to 80%. So the ballpark figure is around 70-75%. Cough also, not a sine qua non. You imagine something's going to hit your respiratory symptom, you'll get cough categorically. Turns out not so. Dyspnea is actually a harbinger of later disease if it is pure COVID. If COVID is added on to comorbidities like we talked about, CHF, COPD, fluid overload, asthma, and so on, it's a different issue. But in severe cases, you'll get half of people with dyspnea, and non-severe cases also, because of early involvement, which may not be seen even on X-rays, but seen on CT, they can have that sort of dyspnea. Anosmia, it was like we love to have these oh, I got something new sort of thing. So it turned out anosmia, where the virus directly affects the olfactory buds, may be quite sensitive, but turns out it may be with most viral infections. But COVID season, anosmia is equal to possibility of COVID infection. And so if you combine the clinical syndromes with a multitude of these entities with anosmia, then an attempt was made to say that, okay, maybe you have COVID-19 more categorically, but it's an attempt, and none of us would hold on to the fact that this is categorical in terms of clinical predictive ability. Other symptoms are a dime a dozen. You can see pretty much anything you go through can be in the gamut of COVID-19. And that's why humbly we have to accept that clinicians were great so far. But in this particular entity, because of the stakes, very high infectivity and very high morbidity, unfortunately, clinical medicine takes a mention, but a relative backseat, so to say. So with this background, what is the other concerning fact? Well, most people are asymptomatic carriers, and this is coming out more and more today. The Times of India, one of the biggest, I think, sources of information for all of us, turns out to be newspapers were jumping on this day in and day out. WhatsApp, social media, and a whole bunch of things out there. It turns out that a study by the Center of Evidence-Based Medicine looked at many disease cohorts, and they found out that 5 to 80% may be asymptomatic, a massive number. So these guys, or even us for that matter, walking around, may be pretty well carrying the disease, which may not matter to us, hopefully, but then we are also, nodal people to spread this whole infection and take it to our homes and give it to the more vulnerable population. So more and more worrisome when you can think that in a disease where you like symptoms, you don't have people symptomatic, or they're turning symptomatic late, and then the symptoms are non-specific, and then the harbingers of clinical diagnosis are not really panning out over here. So another entity which came out was called pre-symptomatics, where they'll get symptomatic later. This has been the phenomena in a lot of these Mumbai hospitals when these guys were taken up for surgery, got fever later, turned out they had then investigated to have COVID, and then the just Lokes or the Wokhats or the Car Hindujas and a bunch of them shut down because they had to do a lot of disease detection and containment. Children and young adults especially can be asymptomatic, and that's what's coming out as being the epidemiological characteristics. A BMJ study again reiterated the same thing, that a lot of people may be asymptomatic or pre-symptomatic. Then comes down to how to understand COVID. If I just going to create confusion for all of you, then how do we understand this disease a little better? So let's add some clarity and try to remove the clouds of confusion. The disease spectrum seemed very variable. What is the most worrisome and what put people on the back seat completely was COVID disease per se. New York, huge amount of intensive care beds. UK converting ICU beds like crazy. Those are COVID disease with respiratory affliction or other serious organ afflictions, and they are being treated as proper COVID majority patients. Then comes other issues that we have comorbidities, and I have, for example, asthma or some sort of a heart issue, and then COVID gets added onto it. So now I have a mixed symptomatology, and I have to try and figure out how much is the COVID component versus the primary disease component. And both of them may wind up worsening each other because of the dance of pathophysiology. And that's another thing which we're seeing right now. A typical COPD exacerbation comes in. He's an old patient known for a long time. And then you send up the test and he turns out to be positive, and you're stuck wondering whether it's a COVID related entity or it's a COPD entity with a COVID contribution. Then comes the dyspnea mimic. So now because of this, we got stuck that anybody with dyspnea in a stage, especially of community transmission, can have either contributory or additive COVID. And this is where we are now really looking at trouble. And we're very glad it's not winter. Otherwise, in winter, these guys keep on coming and we really would have been in a fix trying to figure out what's going on. Another new thing which came out, those cases we spoke about in Mumbai, operated later fever and turned out to have a COVID positivity. COVID unmasked by stress. So surgery in one paper coming out now may, make the immune system more vulnerable to COVID. So asymptomatic or pre-symptomatic people may then come up and get evident COVID disease. Secondly, other disease symptoms. So for example, if I go through again an exacerbation of one of these entities, again, my COVID disease may come up. So these things are another way the disease is manifesting. Then we talked of the incidental and asymptomatic, and this is usually when we test contacts, we're finding these people, or we do community screening, or when you do massive screening like South Korea or Germany and so on. So once you understand this, you must understand that we're declaring this as COVID, COVID, and COVID, but each one of them has a different role to play when it comes to, first of all, the affliction to the patient, contact basis. So example, if I am a contact and I am asymptomatic, okay, you may do what you want for contact tracing and isolation and disease prevention, spread prevention, but I may not get afflicted at all. Healthcare providers, the same thing is going on. So we don't know what's going to happen with, are they coming into this category or they're primarily asymptomatic only. So impact of each disease interaction is being figured out as we look at the positive results flowing in our country or abroad. Myths and realities further continued. Well, testing, I think Vinay may also be touching on some of these things. Only one area, which is either nasal or oropharyngeal swabbing, suffices. Turns out the lower you go, the higher is the yield. So now both are recommended to enhance yield. Another myth is that a negative swab rules out COVID, and I wish that was there. Wish we had a better clinical diagnosis. We wish that we had a test which had lovely sensitivity and specificity. Turns out because of the way the swab is done, because of the viral load at that point, which at the stage of disease you are in, the number of days into the illness, the sensitivity of the test per se, many wildcards over there. We have all these numbers which are highly unsatisfactory touted. So you need some sort of a extra correlation beyond the swab when it comes to diagnosing COVID. But you know what? This is what we have at this point, and we have to deal with it, understand it, and implement it in our algorithms. Rapid antibody testing, so as we jump on every new thing, it's drowning people clutching at straws. It came out there, currently again work in progress. And as we say, COVID data, literature and realities are jumping and either adding or changing every week. Rapid antibody testing is recommended by ICMR only for those cluster areas as an add-on testing, because we don't have the kits, we don't have the facilities to test such a huge population. So algorithms have been put in place. For you and me, it's not of great use at this point, and its role still needs to be defined. People are trying to put it into surgical algorithms, which I think Vinay we may touch on, but currently no rocket science at this point. Another myth. So we'll be shifting from disease myths to what's the public health myth. Lockdown will fix it all, and this is especially in the lay population. They strongly believe that lockdown will make a big difference. Well, lockdown, as we all unfortunately realized when it got extended, that it will slow the spread. Great, lovely, amazing. But one of the main agendas was that get healthcare ready, get your strategy on the ground ready for these 1.25 billion people. And that is something which we really have to work on, but may not be doing as good as was originally planned. Another myth is that the first responder, the government centers can manage it all. Well, the middle class and the upper class is used to the private sector. We're writing an article which we're trying to say that in a proper survey done in last year, the private sector to government center utilization is literally 3 times. So I have to understand that the private sector, much as it tried to shy away and say, let's do business in usual and let COVID go away to somebody else, we will not be able to escape, because if it comes in the numbers which are concerning, we will have to face it. And let's not shy away from the fact that talent and leaders are abundant in the private sector, and you have to respect the pre-existing status of disease treatment in your country before you try and only put it into one area such as the government. And similarly, we had looked at a survey where we did it in 4,500 middle and upper class people, where people were quite scared. And they also mentioned that, they did not have complete confidence in India's government infrastructure. And actually much different from what private guys are thinking. They will pay for care, which was a major thing when you tried to do private planning. So this was another thing that we have to get ready in our sectors. Another myth about people who wanted to shy away from admitting COVID cases is that, let's wait for the cases to come. Turns out, and we have seen this in great force with much to our chagrin in the last week or two, COVID cases, if they come in that category of, as we talked about, incidental, asymptomatic, or discovered later, when you didn't have your precautions, your thinking, and your PP into place, can completely take down your staff, your hospitals, your morale, and so on. Secondly, mixing these cases with regular labs, radiology is challenging. People keep on talking on doing CT scans. It's not going to be easy. These guys stay in the hospital for a long time. Face it, our hospitals were never made for such high infectivity situations. And then we have to really plan well. Otherwise, we've seen many hospitals of repute collapsing initially when they were unable to plan this and think of these things. Another myth was that affects the underprivileged, and the gentleman who talked of herd immunity. One of the exit strategies of COVID is herd immunity, much debated, much touted with lots of people on both sides of the fence. He himself wound up in an ICU in St. Thomas, and the best of the best, basically, including state leaders, were affected. Understand that all these guys, and predominantly we at the front line, are the most vulnerable, with Italy also reporting its 100th, I think, healthcare workers who I think were literally passed away because of the COVID affliction. We believe that we as younger people, some of us as younger people, not me maybe, may be affected. And this chart shows you age and comorbidity related mortality. Good news, kids are safe. Good news, less than 40 doesn't seem to be that bad. It takes a turn above 50, and then above 60 is a problem. So these guys pretty much are out of the medical workforce in a major way. We're finding that a lot when we're trying to do resource allocation. And a lot of people with comorbidities, especially simple things like we never really thought hypertension would be that bad, turned out to have a higher risk of comorbidity related mortality. So these are not only making us worried, but also knocking out the workforce when it comes to healthcare. But they give you an idea of whom to focus on when it comes to putting your resources. So this is something to think about. And then came a question from one of you guys that why do young people need to follow the rules? I'm young, I'm healthy. Why do I need to sit? Why can't I go? Turns out that those were lovely statistics which came out of the original cohorts, but morbidity and mortality is varying in different series. And so the UK, the Italians, and even the Indians are now saying that doesn't turn out that it's true. that it's not that point something, but it's actually more for younger people. So we don't know exactly about the virus hits in different races and sex and socioeconomic classes. And the fact is that sometimes your hyperimmune response may be doing it. So we can't really take it as a panacea. Second thing, which is not talked about a lot, that you as a young person, if you are asymptomatic carrier, at this point at least, the system is worried that you're going to perpetuate the cycle of transmission, take the disease to your elderly, and who are really basically vulnerable. And lastly, if you're in the effective health situation, be out of the effective workforce, which is a big thing. As it hits us and we have to put people into quarantine, valuable people trained for many years are not able to help us. And if you get quarantined for 14 days and sometimes more, because people with the 14-day positive test are going for even 28 days, then it's an important thing to factor in when you are talk of not only the impact on you, not only of morbidity or mortality, but on the fact that you're out of the health area. Medications, there was a question on that. We're not going to spend a lot of time in that. I'll be happy to share some of these slides, but this is fairly available everywhere. These are the ones in red have been the most talked about and effective and part of studies. Hydroxychloroquine, chloroquine to some extent, azithromycin, remdesivir, not available in India at this point. This new drug, favipiravir, which is again seems to have promise, but not available to us. Tocilizumab, sorry for the typo there, which is an agent available to us for the cytokine storm part of it. I'm not going to go into detail. And many other entities such as convalescent plasma and the vagaries of what happens in intensive care. Oxygen therapy, non-invasive ventilation, high frequency nasal cannula, ventilator strategies much talked about and WhatsApp videos coming all over the place, and a strategy for anticoagulation as we try to think that COVID-19 is much more than the regular lung injury. Lots of data evolving. For those of you who like to get a number, around 1,350 papers have come in the last week on COVID. So you can imagine it's impossible for any one entity to try and troubleshoot. We really have to have teams taking care of all these things and integrating evidence. Also, we're getting knee-jerk responses and low-quality evidence. So we have to put everything into context and try and interpret what's going on. Unfortunately, it's not hit us in a big way so far. So we have some time to do all that. Question on hydroxychloroquine, I'll make it quick over there. A lot of clinical trials, all of them at different stages, but they started early, late, doses were different, populations were different. So this French gentleman who looks like one of those Lord of the Rings characters, who basically said that it works magic, and which made Trump even jump on it, has been the maximum proof. But understand, these are abstracts; they're not detailed, peer-reviewed, much audited publications over there. So currently, HCQ treatment came because of these studies, has made it to the guidelines, but on a pure front, still not clear. But major studies are going on, which in the next short amount of time, we think 4 weeks or so, should answer this, as US puts on 500 studies each arm in these studies. Similarly, prophylaxis, which was, I think, the flavor of the disease spectrum in the last 4 weeks ago, and all of us were trying to procure and pop this particular drug. Again, preclinical results showing it drops viral load, whether it prevents the disease, reduces the intensity of the disease, which population nobody knows. And so that is something we'll talk about when it comes to recommendations. QT prolongation as a side effect, especially those who have risk factors, is a precaution to take. Similarly, BCG vaccine, that we in India, lucky fellows after 70 got BCG, and so that's why we're being spared. No concrete data, trials still in progress. ICMR recommendation for HCQ as an early thing. So ICMR had to come out with good stuff initially, and it was based on the same abstracts and experiential review. They said, okay, give it to people, but give it only to healthcare workers who are asymptomatic, who are in the front line of COVID care in the dose mentioned, and asymptomatic household contacts of lab confirmed cases. They did not say give it to everybody as it was done, and HCQ rapidly disappeared off the shelves. Fortunately enough, was still there for PM Modi to supply to Donald Trump as the need came by. Exclusion are the standard, things where the drug is going to do harm, and that's been something which has been factored in. Let's be futuristic. What lies ahead in the next 3 to 6 weeks? The lockdown is going to go, we hope, but in part, we know that for a fact. Community spread, again, not declared by ICMR, but in cities and areas, it is happening. We think it's a reality. Only thing, it varies in different parts of India. We are really worried now. Every respiratory illness, every shortness of breath, every dyspnea is a potential COVID, and we are stuck at this point because of that when these hit our hospitals. And they put under the category of SARI, severe acute respiratory illness, which is a whole entity by itself. When these patients hit our hospitals, we are worried where to keep them. We never planned for these negative pressure rooms and tons of isolation rooms, and they can cross-infect the innocuous patient who's come for not non-COVID treatment. And so everyone's worried how will work go on safely, and there's I'm sure tons of questions coming on that. And then what was the most depressing thing, that this may go on for months because pandemics behave that way. And when it comes to resource allocation, the vice premium of Lombardy, Italy, which was hit so badly, one of the lovely areas everyone wants to visit, he said that we should never have cohorted these patients, we should separate them. And that is a message going around to the whole world as you try and plan for COVID care. So what are our roles in healthcare? Again, acknowledge the issues. That's why we're sitting here and trying to learn all these things. Plan. To understand we're waiting for somebody else to do it. It's not. You guys are bright people, high IQ. I think everybody can master some sort of basic learning curve and integrate information. Train your relevant people over there. Audit it, because if any of the processes break down, especially infection control, we're going to be in trouble. So obsessive audit and modify as literature comes in on what to do, how to do, and innovations pour in, which is the need of the hour. So to put things into perspective, the COVID truths, as one would call them, it's here to stay. Its adaptation is a task of a lifetime. And who moved my cheese is as true, and I mean more true now than it ever was. COVID data, as I said, is changing rapidly. Issues vary from setup to setup. Everybody from supply chains to factories to information technology to government to medicine to different setups in medicine are wondering how to deal with their own problems. It's cutting across all specialties. So it's not only you and me. Because of the high infectivity, non-specific clinical picture, the test vagaries, and of course, one weird thing which we never saw, that doctor-patient community all scared of each other. It's something we've never dealt with in healthcare. It's something never which has crossed our thresholds when it comes to dealing with so much violence, angst, and fear and panic. COVID arena, I would urge you that it's basically whenever you think you're going to think at 4 levels, we are all worried about personal, but then you have to think of your individual areas where you work, your organizations, you're a part of them, so you have to contribute, and each one of us is part of the public process of trying to deal with it. We all know that. COVID tools is understanding as we're trying to do. COVID precautions, just like universal precautions came into the picture, we now are redefining the highest level of infection control with COVID precautions. And PPE and how to do, what to use is a major struggle on the ground at that time. And as I said, it's very important to personalize in your own setup, because you don't have to be a domain expert. If you're sitting at home anyway for the last 3 weeks, and it behooves each one of us to go beyond Netflix and enjoying and try to understand this, at least to try and apply it practically in our own setups. COVID prophylaxis and treatment, what we're waiting for, pop a pill and take treatment, all experimental. There's no categorical treatment. And that is why this particular slide tells you that this is a disease like never seen before, and we need to think of it accordingly. The wild cards, personal note and beyond. Well, people, this is the question, so we're trying to answer that. I'm reassured with data on low mortality, 0.6% in the Lancet study, when they said that you take the whole denominator and test a whole bunch of people and then look at the afflicted and the serious ones, it's not too bad. And we've seen worse. Understand that currently we have live proof of New York, literally decimating, and so many people get overwhelmed because the speed of those people getting involved is basically is getting healthcare into trouble. And you all know that we don't have the healthcare infrastructure to deal with this. And the cost of COVID care, sorry for this typo, is humongous, with people doing all sorts of charges and charging for PP and what have you. And we, as first off, don't have the facilities on the ground at this point also. Another thing is I can work normally again very soon. Well, unlikely. COVID has heralded a paradigm shift. At best, we can work with modifications and ride it out. At worst, it's going to be devastating. So we need to understand this. Skilled manpower is crumbling. We are struggling every day as our nurses, housekeeping, our doctors itself don't want to do a COVID work, and we're trying to encourage people. Every parent wants to pull their child out of healthcare as the news spreads. And so the anxiety and panic is not only in the lay population, but has deep roots in healthcare also. Resources, cost to run practices, healthcare costs, direct and indirect, efficiency is going to come down. Even if we open, social distancing is something we never practiced well. I can't even imagine how our outpatients, inpatients, and hospitals are going to run. We've got to think it out. PPE cost is humongous and breaking the bank. It's going to be worse than the drugs which were talked about as being the incriminatory factors. Manpower cost, because people will drop out of the manpower spectrum as they do duties and so on. And infrastructure cost to convert to a COVID center is indeed humongous. So it represents a tectonic shift in healthcare delivery. What do other people do is what also was given to us as a question. Alric himself has written a lovely article on a blog. You can go and see it if you want. The blog is drravindramehta.com. Forgive us for the name, but it was somebody helped us to create it. How other non-domain specialties can help. First of all, what we're doing right now. Then how are you going to work to integrate that with the guys who are going to help you, like infection control and some of us. And then, of course, the thing is, if we get to the UK, US, Italy, state and all, then they will be trained in basic care aspects, triage and use your native skills in your specialty. Orthopedic guys are being used to turn people. Vascular guys are part of line teams. Anesthetists are part of intubating teams. Many such things have been created in the Western world who's reeling from the COVID onslaught. It's all not negative. What to hope for? The silver lining in the COVID cloud. Well, the good part, epidemiological predictions of a horrible nature have been mitigated by an aggressive lockdown. So something right we have done, and something is, the good Lord is beaming at us as we're doing something correct. We're realizing that most people are mild or asymptomatic. And then we'll have to answer this big question, that is there actually a major clinical implication of the asymptomatic, or they just spreaders and that's why we're getting worried. So all this will come in the down the line, and we have a sense that it should not be as bad as is being projected to be, or as the fear indicates. Young healthy people, children, lovely statistics. They're doing very well in all spectrums, uniformly across the world. SD is something India never knew about. So we now going to get more geared up. And as we open, I'm sure I've never seen people lining up in boxes in stores. And that will be something which will be part of our culture as we try to gear up towards post lockdown phase. Work for home, technology, webinars. I've never done this in my life. All this is going to redefine the space in work and how we talk, lecture, and look at our education. And an entity called reverse isolation of the elderly. Keep them at home even longer, because they are the vulnerable population who will both go down and also be the main brunt of what healthcare has to deal with. We hope that technology will keep up when it comes to tests, antibody tests, and the roles will get better defined. Similarly, the maximum amount of research is going on in COVID care, and we hope that herd immunity, vaccines, and so on will come to us, so it's going to take a lot of time. Treatment will be better streamlined is what we are looking at, as every week we're getting more and more data. And then the entities we mentioned as we came up with these entities. Human adjustment time, when the initial panic, fear, and anxiety settles with more maturity, and the corona coexistence paradigm will sink into each one of us. We learn to live life with this disease, especially when we know how to deal with it. So to summarize the whole talk, the COVID approach will be by and large accept and understand, see the need for what we're doing and the need for what we have to do constantly, understand the differences from the old epidemics of H1N1, tuberculosis, and all the villains, which we also thought till a month ago, what is the big deal? But this is a big deal right now. And once we understand these challenges, we're in a better position to implement what we have to do at a personal level in our lives, in our home, in our practices, and in our organizations. Do that correctly so that we are safe and our patients are safe, and we break the cycle of healthcare and public and patient dissemination. And of course, public health roles, which we all have as citizens as well as healthcare providers. The basics of all care are the three P's: your place of where you reside, work, and exist; the PPE conundrum, which is breaking us, but which should get better over time; and the personnel, which each one of us is part of it, which are so important to fight it once we get the deluge into healthcare, which we hope not as the lockdowns ease up. It has to be a solution-based approach. We are inundated with our people also in a hospital just asking for somebody else to do it. We'll have to do it. No admin has been never geared up towards all this stuff. Dynamic adjustment, as we say today, that what we said yesterday was not correct or needs to be taken in perspective. And of course, as we are trying to do today at 9 p.m., we're supposed to sit and light a lamp as per IMA, frontline staff protection, both on the PPE front and on other fronts. And as we help each other across specialties and across lines to try and get this under control. What we're still tackling is unfortunately the tip of the iceberg. We have a huge amount of work to do in healthcare if this ever reaches even a fraction of the volumes which the Western world has seen. And this particular cartoon often comes to my mind. This particular pilot jumps from his burning plane. This is post-lockdown, only to come into this area full of crocodiles. This is what we will face if we are not prepared to handle our cases and continue the discipline which is so imperative. This is what was the initial reaction: business as usual, let somebody else do it, not working so far. And I like to end with some inspirational quote which has kept me going and a lot of us, that when Greta Thunberg, the young girl who basically got up in the UN, said this, that this is the biggest crisis humanity has ever faced. This is not something you can like on Facebook. She talked of climate change, but is actually much more valid for COVID-19. And JFK said in 1962, great crises produce great men and great deeds of courage. This is the need of the hour. Nelson Mandela left us with this thought provoking statement that when a man has done what he considers to be his duty to his people and his country, he can rest in peace. I believe I have made that effort, and that is therefore why I will sleep for eternity. We need to rise as a system. And we left this message for all our teams who are panicking initially but are now ready to face it. Stop trying to calm the storm, calm yourself, and let the storm pass. Thank you very much.
Great. Thank you so much, Ravi. That was extremely informative. I think you had a very balanced and nuanced approach, showing us some scary predictions of where the world is headed with this new pandemic, and at the same time giving us some reassuring thoughts about what we already know from evidence that has come in over the last many months. I agree with you that a lot of things are still unknowns, and while there is fear and panic around, I think we as healthcare professionals need to have a very balanced approach, especially when we guide our patients and our close ones as to where we stand. I'm sure there's going to be a whole lot of questions, and you have answered some of them very admirably, but there will be some more which I will bring on after the second talk, so that once we have the perspective from the ID specialist as well, we can put all our questions together. So thanks once again, Ravi, for really sharing some really wonderful thoughts with us. I now invite our next speaker, and that's Dr. Vinay Devraj, who is a very eminent young um, infectious disease specialist from the Apollo hospitals in Bangalore. And he will cover some of these topics that are quite relevant to us as healthcare workers, especially us surgeons. And Vinay, you're addressing a whole bunch of orthopedic surgeons here. And some of us work in corporate hospitals. Many of us have nursing homes and our own little practices, our own little hospitals that we look at. And while all of us are chafing under the fact that we are stuck at home for the last 1 month or so, the important question is we have to keep those nursing homes running. We have to have our staff looked at. They have to support their families as well as we have to do ours. So I think some of the questions that are going to come in towards the end will be again, that real important question: when do you think it is safe for us to restart? And if we are starting now itself, what are the precautions we can take to keep ourselves, our staff, and our patients as safe as possible? What are the sort of work that you think we should start off with, uh, and then proceed further with more elective work? So, Vinay, over to you.
Thank you. And if I can start off by sharing my presentation as well. One moment. So I hope I'm audible and my presentation is visible as well.
Yes.
Yes, thank you. Right, so let me start off, and this works. Give me a moment, I'll just fix it. Yes. At the outset, let me begin by thanking the office bearers of POSI, Dr. Alaric in particular, and Dr. Ravindra Mehta for giving me this opportunity. And I start by apologizing because I had very less time to prepare my slides. And so I'll talk more than what I present on the screen. But these will be a few of those important aspects which I'll try to cover, wherein infection control aspects at an individual level, community level, and at a healthcare level will be dealt with in this talk. And since we are discussing about various aspects of when to operate, how safely to operate, and then how safe is to operate at this point of time, let me go through a few assorted recommendations rather than guidelines, which can act as guiding principles for surgery and to initiate surgery at this point of time. There are a lot of doubts, some small and some big, at an individual level and at a corporate or a healthcare level as well, If I can start by addressing a few of the smaller ones, I mean, what we know so far, this is what is happening since the month of December. I mean, few guys, these ones are roaming around, whereas bulk of us are in the stage of lockdown and encountering few old nemesis as well for that reason. New learnings, new beginnings, and then new behavioral changes and all. So sitting back, not working much, it has led to a lot of doubts. Even the small ones appear as bigger ones. Depending on my interaction with a lot of healthcare professionals and the non-healthcare individuals as well, gauging at what troubles them or what kind of doubts they get, I've tried to address few of the important ones as well, and then few which may look and sound minuscule as. What we know is the concerns are, yes, I'm at home. What do I do? Is it really of that great concern? Whatever I get into the system, into my home, can transmit the infection. So what I've done is I've liberally used a lot of slides from WHO, World Health Organization, which many of us would have already looked at. And the panic is more than the fact at this point of time. So what we can do is we can all go through those websites and understand that the transmission of virus by and large is by the way how Dr. Mehta has described. So fomites, food items, or any other things as a mode of transmission at this point of time have not been proven. So just maintain good hygiene, hand wash, safe distancing when you go out is all what is required. So I want to go into detail of that. But what I would like to touch upon in a bit of detail is what happens. You're a healthcare worker, you go back home, or there is someone who's suspected to have COVID or coronavirus infection in the family. So what are all the important infection prevention aspects? So we can segregate that into three different components. One wherein none of the persons or people in the family are sick, but since you are a healthcare worker, you are always at risk of transmitting the infection to others. So how should it work? At this point of time, once we start working in the hospital, all of us are potential carriers of infection. To the best of our knowledge, to the best extent possible, we try to prevent that from carrying it home. But if you go home and you think you might transmit the infection, basic infection control measures come into picture. Wash hands regularly. Stay away from anybody who can contract infection easily, like those who are elderly, those with bad diabetes, those who have immunocompromised. It is always wise to maintain safe distance from this set of population. And what I suggest is follow the infection control measures of good hand hygiene, good hand wash vigorously. If there is someone who's already sick, it is crucial and vital for those to be tested. At this point of time, the testing strategies of government, which I'll discuss later, are not liberal enough. But if somebody whom you're in contact with or anybody whom you know are in contact with do have some respiratory symptoms, it is vital that they are considered as possible corona or COVID suspects. And then testing is vital because that is the only way where we can diagnose the people with infection or carrying infection. Because if this window is missed, one, the infection can progress. Two, they can start infecting others as well. So if there is someone who's strongly suspected to have coronavirus infection or is proven with coronavirus infection and they are not sick enough to be hospitalized, wise thing to do is isolate at home itself, have a separate designated room, ideally with the attached washroom. Good hand hygiene measures should be kept in place, dedicated instruments for them to make use of, utensils for them to make use of, and once that is made use of, it should be washed and then handled separately. And if there is any sort of worsening of symptoms, it has to be reported immediately to any sort of healthcare setup that you are approaching. So the same for those who are giving care to those who have proven or strongly suspected COVID-19 symptoms. So just, keep them separate, keep them away from children, keep them away from elderly, keep them away from immunocompromised individuals, do good hand wash. And if you are one who's caring for such individuals who have a proven COVID infection, but they are to stay back at home, wear masks and then follow a vigorous hand hygiene routine. Clean everything in and around the room, particularly those areas where you touch or come in contact with frequently. Say it may be a table, it may be a doorknob. You can use anything which has some alcohol content in it. Anything like a hand wash or a hand rub, which has 70% alcohol, is more than enough, or a phenolic compound is more than enough to wipe clean these areas, and these act as disinfectants as well. You're a healthcare worker, you go back home, and with a potential risk of you carrying the infection back home, what all can you do to prevent transmission of infection? First and foremost, as soon as you reach home, yes, the ideal thing to do is not to touch anything which are commonly used or frequented by other members of the home. you wearing shoes and walking around in the hospital, please have a designated area where you can dispose or keep your shoes away from the rest of it, away from the rest of shoes or slippers of your family. The third part, I'll not go into detail. Now, what happens to the clothing? Cloths are potential contaminated components which can transmit or disseminate infection. So what is suggested is, if you start working regularly, and if you're in a setup where there is a possibility that infected patients may be there and you're coming in contact with them, as soon as you go home, have a designated instrument or a utensil where you can drop your clothes. Ideally, it should be dipped in something like a Savlon or a Dettol. Though bleach is recommended, it is not good for clothes. Savlon or a Dettol, soak it for about half an hour and then wash separately and then sun dry them. This can be done on a daily basis. Whatever instruments which you make use of regularly, say maybe it may be keys or purse, do not mix them with other items, and then have a designated area where you can use it only for yourself. And like it's mentioned here, once you go home and you have your clothes being taken care of, shower and shower well. It is always ideal to shower off at the hospital or nursing home or whichever healthcare center you're working in. If that is not possible, as soon as you go home and clothes are designated, kept in a separate place, shower well, and this is what you need to follow. And like the last part mentions, to the best extent you can do, you try to eliminate infection. It can't be 100%, but you can only minimize the risk of it. So the summary of this is, take as much care as possible that before you come in contact with any of your family member, try to dispose all the things or try to keep separate all the things which you are carried around in the hospital or in the healthcare setup. Now, what can be done at a community level by and large or at large? So it's like history repeats. What happened in 1918 Spanish flu, the measures were well set, well understood, and well applied even then. So it was a combination of these four factors. Social distancing has been, I believe, an overused term. It should be a physical distancing, because social distancing has led to this concept of community vigilantism, wherein people think anybody who sneezes or coughs, they are looked at with suspicion. And I think they may be instances where they may attempt to lynch also. I think a lot of things are happening in and around our centers, our states, which we're seeing already. So physical distancing is the right term and the right thing to apply. Cough etiquette, yes, it's been tried, tested, it's well proven. If you can do that, you'll prevent transmission of infection. And those who have suspected symptoms or have come in contact with anybody carrying the coronavirus infection, self-quarantine is the best way. The top three measures have clearly been proven beyond doubt to add to the measure that infection can be prevented if you follow it well and good. But the last measure, which still is a doubt whether or not it will prevent transmission of infection at a community level, I'm talking about a community level transmission, is the one which is being lapped up with all its preparedness and earnestness, because it's an easier thing to do. If you look at the scientific principle of masks preventing infection, the basis to that, or basis to what states or countries recommending the use of mask, is that when you cough or sneeze, and if you're infected, these come out as droplets and aerosols. To simplify, droplets are those which are larger in size, and being larger in size, they cannot move beyond a distance of 1.5 to 2 meters. That is 3 to feet distance. So initially, when it came to coronavirus, CDC, WHO, everybody gave a recommendation because it is very similar to H1N1 or influenza. It cannot traverse more than 3 feet. So 3 feet distance is good enough. Now, understanding or concern or evolving concept is that it may traverse a distance up to 2 meters or 6 feet. So 6 feet is what is now recommended as a safe distance. So the physical distancing now goes from 3 feet to 6 feet. So these droplets cannot move beyond 2 meter distance. Whereas aerosols are droplets which are very small in size, like these ones. These can traverse a distance of more than 6 meters. And in certain conditions, aerosols which come out of a person who has pulmonary tuberculosis can traverse a distance up to 100 feet as well. So that is 30-meter distance. So for that reason, aerosols cannot be that easily managed. But fortunately, the current infection of coronavirus is not believed to be aerosolizing so easily unless until some procedures are done. It is by and large a droplet transmission. So how does mask help? So this is a scientific prediction model and a simple lab study which showed that if you wear a mask and you're in a community where there are a lot of people who are coughing or sneezing, if you use a cloth mask, there is a 33% chance that these materials might leak into the mask and you may inhale them. If it's a surgical mask, then it is 25% chance. But with an N95, the chance of it is 1%. So it seems that N95 has the maximum effectiveness, but try and wear N95 for more than 15 minutes, it is suffocating. So advising it at a community level is not possible. Even with surgical mask, it is not possible. Also, for the reason that surgical mask and N95 are equivalent to gold right now for healthcare workers, it is not advisable for anybody and everybody to wear these masks in the community. So any cloth mask with added measure of physical distancing should help. Now, if somebody is infected and is wearing any of these masks, are they really beneficial? If you look at it, practically no, because if somebody is really infected and wears a mask, 90% plus of those materials, if it's a cloth mask, can come out, and even with an N95, 30% of it can come out. So just mere mask will not solve the conundrum. You need to add mask along with other components of hand washing, good disinfection, not touching your face and mouth, eyes repeatedly or frequently, and physical distancing, which none of our population are buying into. So even now there are a lot of buying, you just do anything which is easier. That is, wear a mask is easier, but physical distancing doesn't seem to be easy and well understood. So it's a combination of all these which can prevent transmission of infection at a community level, and mask alone never solves the issue. History also has taught us that is what happened in Spanish flu as well. Now, there is a large myth which was propagated about this disinfection tunnels. I'm just touching upon it so that everybody understands, because this seems to be a fad. There are a lot of companies which have now started manufacturing and then promoting it in a big way. Now, Government of India also has taken cognizance and it has warned against the use of disinfectant tunnels. These are of no use at all, because by and large, when you have a respiratory infection, the portal of entry and persistence is the respiratory tract. So nobody is going to come close and sniff anybody. The virus sitting on the skin can enter into your respiratory system. That's not going to happen. So passing through a disinfectant channel and disinfecting your cloths or skin, it will not make any difference at all. And also these are filled with sodium hypochlorite. So many of them can be allergic to it, may trigger off something like a bad asthma or worsening of COPD, or maybe an unknown allergy as well. So disinfectant tunnels are a bad idea. If anyone is buying into it, I think please come out of the idea that disinfectant tunnels do work. They do not. Now, let's start looking at healthcare level. So when it comes to healthcare level, at this point of time, the questions that Dr. Alaric asked, when can we start practicing? So at this point of time, Dr. Mehta touched upon the aspects of HCQS. Now, HCQS has taken in a big way in terms of pre-exposure prophylaxis, post-exposure prophylaxis, and there are a lot of concerns, debates about whether or not these help. Majority of healthcare workers have bought into the idea that you take HCQS, you are protected. That is the concept of PEP has sunk in deeply, but trust me, what helps more than PEP is PPE. If you have a good personal protective equipment, you can proceed well and then proceed a bit more safely. So what should be the PPE? Not everybody gets to wear, or not everybody needs to wear the complete gown or a military grade protection if we are working in healthcare. So just like what is shown in the picture, the type and appropriateness of PPE depends upon where you're working, what are you working on, and what zone are you working. So this is a simplified protocol that we have created at Apollo, segregating individual groups and staff based on the risk and based on the type of exposure. If you see, those things which are in red are marked as A. These are the areas where high risk cases can walk in. OT is also considered a high risk, wherein your exposure to the patient is of longer duration, is in a very close range. So it is always possible that you might pick up some sort of infection from these individuals. So this is considered as high risk. An high risk or an individual working in a high risk zone gets a full grade protection, which includes an N95, includes protective goggles, a water resistant gown, double gloves, shoe cover, and a hood, very similar to what this gentleman is wearing in here, trying to protect you to the maximum extent possible. So various other sectors, depending on what is the level of exposure, the level or extent of PPE also comes down. So just you have a PPE, is it enough? Is it enough for you to start practicing? So let's start with an OPD practice before going into surgery. So how can you run your OPD efficiently? Should you depend on PPE? Should all of you wear a full grade PPE and then sit in OPD and then start working? Now, what we have learned in the last 2 months, ours is a corporate setup. I mean, we have 3 units of Apollo hospitals running in of various size and various grade and various bed numbers. What we have learned is PPE alone is not merely enough. And PPE at this point of time, like I said, is gold. It is not an inexhaustible resource. At some point of time, we may run out of PPE, like what has happened in the Western countries and all. So you need to ration your PPE and use it very wisely. So to do that, you need to risk stratify your working zone your hospital, your OPD system also. And it all depends on a robust screening system. So what I mean by a robust screening system is you need to have people who can sit in that, who can sit in a screening OPD, screen the people who may have doubtful respiratory systems or anything, respiratory symptoms or anything which may point towards an infection. In our case, since ours is a multi-speciality, I mean, we have involved medicine and subspecialty and infectious diseases team, wherein we wear the full PPE, we have a full screening OPD running, and we screen these patients based on a screening questionnaire, the symptomatology and examination. If it is seen that they do not fit into any sort of criteria matching COVID-19 or coronavirus infection, these people are let in. So you as a surgeon or any other subspecialty can practice without much fear, because the risk is significantly less. So what are we doing? Like I've shown in this, you still sit in an OPD, you don't need a full gear PPE, but you wear an N95 mask. So there is a second level protection, so you can safely practice. Even now, preferable, since we are in a lockdown phase, the cases are still rising. We don't know what will happen once the lockdown eases. There can be a rush in, or floodgates might open, lot of infected people might come in. It is still wise if you can do to have a teleconsult system running. If you can't do that, you need a robust screening system which can help you to prevent or minimize the infected patients from entering in. And then you wear an N95 mask, use gloves, and use diligent screening system and symptomatology workup for you to be safe. Now, how far can the tests help you in an OPD setting and in a surgical setting? At the end of the day, if you have to operate, you need a patient who's safe for you to operate. So for that reason, you need to know the basics of virology. I mean, what the graph here clearly shows is that if an individual passes through various stages of infection, which I'll not go into detail, but I'll correlate it with the tests. What you see in a blue thick line here is the RT-PCR. RT-PCR at this point of time is the most widely used and most useful investigation, wherein it can be positive even from day 0 onwards, like is shown in the graph, and the peak reaches by about day 14, and the viral shedding can happen up to about 28 days. That means an individual can keep on infecting you from day 0 to day 28, and you can detect RT-PCR or the virus through the PCR system all this while. IgM becomes positive, look closely, only after the onset of symptoms. So in an asymptomatic individual, IgM has no value at all. So only from day 7 onwards or day 6 onwards, the IgM becomes visible in the serum, and then you can start using it as a diagnostic tool. So how do you interpret a test? In simple manner, if you look at this table, anybody who has a positive PCR is considered infected, and he is liable to transmit infection to you in any form. So if an individual has PCR positivity with IgM positivity, that means he's in the acute stage of infection and he is at maximum risk of transmitting the infection. So it is safer to presume that if you have a test, then you can make use of it and then you can interpret it that way. But on a ground level, what is the performance of the test? So these are the data, or this is the data which has come out of China. What you can see is the RT-PCR sensitivity increases by day 1 to 7, but gradually it declines after, whereas the antibody takes about 8 days for it to pick up, and it is reliable only by day 15. Meaning no test has 100% sensitivity. RT-PCR has 100% specificity, that is close to 100% specificity. If you have a RT-PCR positivity, that means the individual is infected. And after day 15, you have IgM positivity, that means individual is infected. So will you wait on for that long? So who is a patient who can be tested or who can be taken up for surgery? Any person who's asymptomatic, has a negative RT-PCR test, has a negative IgM twice over a 10-day period. That is, you're tested on day 5, again on day 15 is negative, and in this 10-day period does not come in contact with anybody who's sick, or he has a negative CT finding for COVID-19, is a safe person. But is this a applicable or a practical strategy? No, it is not, because you cannot use PCR so extensively. The testing strategy is not liberal. Government has not given it to the private players so easily. You can't wait for 10 days and then test the individual twice. It becomes so difficult. Also, the positivity of RT-PCR depends on how your sample is being taken, how your sample is being tested, how far, how long has it been stored, and which is the lab which is testing it. And other added problem is asymptomatic individuals, you'll never think of testing, or most often you'll not think of testing. And what Dr. Ravindra Mehta stressed upon, bulk of our patients are asymptomatic and are transmitting infection in the community. So those who are in incubation period or who are asymptomatic, you won't do the test, you'll not pick them up, but they can still infect you. So having a safe strategy and following this ideal guideline is not possible at all. So this is what the Indian Orthopedic Society flow chart is, it is fairly simple. Unless and until it is an emergency, do not operate at this point of time. If it is positive, take all precaution, take full grade PPE right from the word go. Where you admit a patient, patient has a mask, all your staff are wearing PPE, is wheeled in with a mask, your staff is wearing PPE, and then he's wheeled out after surgery with a mask and your staff is wearing PPE till the time of discharge. So that is the safest strategy to follow. But the problem is, how do you stratify or how do you risk stratify? First and foremost, you should have your own society's guidelines as to what is urgent, semi-emergent, and emergent, and what are elective cases, and you need to wisely choose that, because like I said, everybody at this point of time is a potentially infected case and it can infect you and then any of your team members as well. So risk stratify and see what are the emergency cases so that you can operate on these cases, and also you can minimize your PPE burn rate. That is, you have to always know what is the number of PPE you have with you, and if you operate for an X number of patient, how fast will the PPE burn out. So this is a strategy which has been applied in the Piedmont group, wherein they have clearly identified if there is critical supply, if there is enough supply, if there is more than bulk or luxury supply, only then they will go ahead with an elective surgery. Otherwise, they are using the PPE only for an emergency surgery and not for elective surgery at all. So each society has to come out with its own guideline, wherein what is an emergency surgery, what's a semi-emergent, and what's an elective, what is the PPE availability in your setup, a clinic, a nursing home, or a hospital, and if I operate this number of cases in this week, how much of PPE gets used, and what is my source of PPE, how far and how long can I sustain with this number of PPE you need to get in. Once you wheel the patient into surgery, the simple principles that are to be followed are, anesthetic principles are well documented in all the societies. I won't go deep into detail of that. I'll just touch upon the infection control aspects of it. Make sure that your operation theater has a separate air handling unit, because if you mix the infected air or aerosols with other theaters, it can transmit infection from person to person, team to team, and then there can be an outbreak ending up in catastrophe. So you should have a separate OT AHU. Second, like I said, maintain a green corridor. If you have a strongly suspected or a confirmed case, wheel him in wherein other patients or other staff do not come in contact with at all. And that corridor or that pathway has to be well cleaned and disinfected at the earliest possible time. The people or staff who are inside the operating room should be kept at a minimum. Only experienced anesthetist wearing a full PPE intubates, and then rest of the team walks in. And as per the strategy or as per the PPE pathway which I showed, the PPE should be made use of during surgery. Minimize aerosol generating procedures. And once the surgery is done, you wheel him out with a green corridor. OT disinfection should be done as usual. I think each OT, I'm sure, will have a OT disinfection protocol. Use sodium hypochlorite, Virkon, and any other alcoholic or phenolic compounds. Whatever you use, clean well. Fogging is of no use whatsoever. Fogging does not do anything to the virus. Surface cleaning and extensive surface cleaning is what will make the difference. And once the cleaning is done, allow at least 1 hour contact time before you wheel in the next case. And like I said, always have a good PPE trail. Maintain a good pathway. The patient who comes in, if he's infected, till he moves out of the hospital, staff will wear PPE. You should have designated rooms to handle these patients. And ideally, these rooms should have a well-ventilated setup where air mixing should not happen with other rooms or other staff at all. So this is what I can present to you in a nutshell, how an infection control should happen. When should you operate? You should operate when you know or when you deem it is safe, but we don't know when it is going to happen. So what you should do is consider all the patients who come in as potentially infected, have a good screening system. If the individual is asymptomatic, if you have access to the test, at least one RT-PCR negative will always help. If you don't have access to test, an immediate test, and it's an emergency surgery, use PPE liberally and then operate with all standard precautions which I've mentioned so far. So this is what I can present to you as an infection control strategy for surgery. But when specific questions comes in, I think I'll be happy to help. So at this point of time, what I think me, Dr. Mehta, and most of us agree are, we don't know whether we are brave or stupid, but ultimately maybe 3 months down the line, 6 months down the line, what we do in a refined manner will just help us understand what we have succeeded in and what we have failed at. Thank you.
Great. Thank you so much, Vinay. I think that was a really excellent talk. I think I and many of my friends have been reading a lot about COVID from different sites and different news channels and media. But I think you've done a wonderful job of bringing everything into perspective. And I really must thank you so much for taking out your time from a very busy schedule. I know you're really inundated with work out there. And this is your golden time, really, where we are going to depend on guys like you and Dr. Ravi a lot for our healthcare needs. I think we'll start the question answer session. I acknowledge that you've answered a lot of those queries we had initially in your talk itself, but there might be a few more from the other panelists. But I'll start off by asking a few things. And Ravi, the first thing I think we'd like to answer you to answer is, we have this feeling that this whole thing is being overhyped in India. A lot of people get this feeling that, we're like 2 months down from where the first case started, and we're seeing, really speaking, fewer infections than what we anticipated. Right now, we know that we are seeing about 19,000 cases in India, which, considering the size of our country of 1.3 billion, is like a drop in the ocean. We are seeing about, less than 600 deaths. So, what really is going on here? Is it something that is being blown, overboard? Is there something happening below the surface that we're not seeing? Really, is this time that we should say that we should hunker down some more? Or is it time to say we can let go? We have waited enough of time. We've had a month of lockdown. Let's get back to business. And I know a lot of things are difficult to answer conclusively, but from your experience, what do you feel you should tell us? Because, we're comparing ourselves to what's happening in the US and Europe. We're seeing those cases spiking up there, reaching that inflection point and plateauing, but we are nowhere near what the other countries are seeing. What's your take on this? You need to unmute yourself, Ravi.
Yeah, so I think
It's frozen. His connection is frozen. Looks like he will have to rejoin.
No,
He's
he's
back.
fine.
He's back. He's back.
yeah. Okay, lovely. So, excellent question, which is on the back of everybody's mind, including the guys who are locked in, the guys who are planning, and all the administrators in healthcare, which is reeling with the economic losses. And are we overdoing this whole thing? And all the migrant workers bunched up at 40 degrees being fed by people. For what are we doing all this stuff and we don't have those cases? Look at the background. First of all, you've got experience from other parts of the world where they are dying, basically. They're completely dying at this point. So, you can't you have to take stock of that. Then the guys who really know the writing on the wall are these epidemiologists and these prediction guys, right from our ICMRs to Johns Hopkins, who get together and say what is the worst case scenario, because all our politicians don't have domain knowledge for this. Obviously they need guidance. Then it's realized that those horrible statistics are there, like I showed you, like Bangalore itself will require 1,000 ICU beds, and so the whole thing swings into action. That let's get prepared. First thing we do is we go into lockdown. So if we did not go into lockdown, we would have been pretty much similar to one of those countries which we don't envy at all at this point, where we have been. Our friends are there, but who are, where 50% of UK healthcare staff is infected right now, where the Prime Minister went himself into St. Thomas's ICU. So that is the situation. So you did what you had to do at a point period of time 4 weeks ago, which also was thought to be okay. We could have done it a little earlier, but yes, it was done wonderfully. B, you're seeing the results of that 3 to 4 weeks down the line. The results are partly because of the positive part is that, okay, good is lovely, but also the fact that you're not testing right now, that you don't have enough test kits on the ground. When I put that argument out there, it's out, we really can't test as much. Some people say it doesn't make sense to test. A lot of people saying we need the denominator, we should be like Korea, blah, 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 and so on. But ultimately, we don't know the denominator. The good part is we feel that the sick ones are not hitting our hospitals in large numbers, but that's not true for cities like Mumbai and Indore and so on, where they are coming in large numbers right now. So currently, you cannot hedge on this. If you hedge on this, you'll become a United Kingdom or United States. So that is the clear writing on the wall. Two, we have nowhere close to the health systems of those countries. We are abysmal when it comes to managing these large numbers coming to intensive care. And when we talk, we take it from the horse's mouth. There is no way we can manage all these people, whether it's poor, middle class, or rich class, and so on. So currently, it's a good feeling. You're able to ask this question is a lovely question because these numbers are low. If lockdown had not reduced your numbers, we would be in the biggest mess that the world has seen, because that is your biggest brahmas, as we say, that you could have used to try and stop this whole thing. Now, if we accept that, then we say, okay, we've gone through all this. Now, the most important part is what's going to happen when it opens up. When it opens up, those 80% asymptomatic guys, are they going to come and infect others? How are they going to cause the people to get sicker? And then the most important question is how many of those sick people will reach healthcare? So many unanswered questions. The bottom line is you can't hedge on this. The bottom line is if you're wrong, then you will go through the biggest holocaust that we have seen in our countries akin to other places. And so we are now sitting week by week looking at what's going on, despite the fact that you don't want to see humongous numbers. Lastly, if testing on the ground increases like crazy and people made it easy, it is very difficult to get a test, Alaric. It's not easy at all. We basically have to fill forms, collect the samples, wear a PP. When we do a test, that fellow has to be under observation. You cannot leave a guy who's getting a test into the community. And then only after he's negative, he goes back into the community. If that takes 3 to 4 days in some cities, that is the time interval. So if you see the vagaries of what has happened, the testing challenges, the success of the lockdown, which is lovely, the positivity of the test, you may still have COVID when your test is negative. You realize that this makes sense. Let us not question the results of good to try and go on a side which is concerning, and we don't have plan B in place.
Great. Thank you so much. That was really very important news for us to listen to. I'd like to ask a question to Vinay next. Let's assume down the line that we are going to get infected with COVID, whether it's now, whether it's a week down the line, of 5 months down the line. Many of us live in small or large families. We have elderly parents around with us as well. What do you think would be the best strategy if people of our age get infected? Should I know you put up those WHO guidelines which say, you know, keep them stay in a separate room, but it's going to be so hard on a practical basis. Would it be a better option to isolate yourself in one of those special centers that have been set up, or check in one of those hotels that have been specially set up for quarantines? Because I can't imagine how staying in your own house you can prevent your family members from getting infected from you. So, what do you think would be the best strategy on a practical basis?
Um, like you said, on a practical basis, yes, theoretically, all those things seem to work where you just stay at home. And they seem to work at this point of time when we have not been hit with barrage of cases, and most of the cases don't seem to be severe enough. Most of the guys whom we are advising isolation have milder illness. So we are always advising them to go back home and isolate in a separate room if it is possible. Majority of corporate centers already have tie-ups with these hotels which you are speaking about, wherein they can go isolate themselves because they don't want to infect their families. But when it comes to a point where the lockdown is eased, the number of cases increased, are we really that luxurious enough to go stay back in a hotel? Are there enough number of hotels for us to stay back? I think ultimately it still boils down to us staying back at our homes and maintaining physical distance. I think physical distancing is the most important aspect when it comes to that. If you have a home where you can have a single room for yourself with an attached washroom, that is probably the most practical and easy strategy to do, because not everybody would be affordable to go stay back in dedicated centers and all. And whatever dedicated centers the governments are promising have been turned into hospitals where they're taking care of active patients. It is mainly for patient care. It is not for people with milder illness at all. So you're still left with only two options: either you go to a hotel or you go back to your home. I think at some point of time, these hotels will also run out of patients, not much money made. I don't think, because of the risk of infection and stigma of COVID, they will not allow any more people to just enter in and then sit there for the entire duration of illness. So we have to start thinking, ultimately it's home, home and home. And if you go back home, the easiest way is, like I said, maintain physical distancing. If you have an elderly or a sick patient, try to keep as much distance as possible. And you can provide a mask to them. In addition, make sure you don't go into common areas of the home, of the house. You don't go into the living room, don't go into the kitchen. Make sure it is given to you. It seems a bit too drastic, but that is the most practical way of preventing infection or spread of infection to others and keeping your family safe at this point of time. And also, what we have observed is most people whom we advise home isolation are more comfortable isolating themselves at home rather than stay alone at a hotel and then be scared and then be fearful about their disease as to what would happen next. Because if something has to happen, there is always help. You can just call in the hospital and then you can get help. They're not very comfortable going to the hospital and doing that. So I think we'll have to look at the comfort level as well. And then home seems to be the most safest scenario at this point of time, provided you can ensure good physical distancing. I would say physical distancing is most crucial, practical way of preventing spread of infection to your near and dear ones.
Great. Thank you so much. On the same lines, many of us, especially in big cities, still have Our household helps coming over to cook and do some cleaning. Uh, we are getting groceries from the market. We are getting goods delivered to us. They're all potential fomites. So, what do we do in such a circumstance? Should we really make some effort? I know there are people who take every little bit of grocery and scrub them down for like half an hour and spend a better part of their day doing stuff like that. Every package that comes into your house, you scrub it down, you wash your vegetables with soap and water. So how do we, on a practical basis, take care of all these extraneous things that are entering into our house? Also, the people who are coming to work with us, in a way, we want to help those people. They are, in a way, they need the money. We need help as well. How do we keep ourselves safe from these two things?
Yeah, I think that's the sad part, that we don't have any clear-cut answers for them. I think we have evolved over last 2 months, modified, and then have done a bit of improvisation. I think when it comes to house helps, maids who come in, what I would practically suggest is that monitor their symptoms. I think let them be honest, take them into confidence, and then tell them if you have any sort of doubtful symptoms, we'll always support you financially and otherwise, health-wise also. Do report symptoms, because if they are symptomatic, the chance of them transmitting infection to anybody in the family is more. Now, provided they are asymptomatic, provided they are not infected, which you can never find out, and if they are working at home, again, physical distancing makes a lot of sense. Let them clear off all the area, and the common areas where they have come in contact with, what most of us feel is that should again be cleaned with something like a Savlon or a Dettol or any phenolic or alcohol compounds. And these common areas are usually the table edges and then door knobs, which we frequently touch. So monitor for symptoms and then clean off the commonly used areas. You can minimize the risk of infection when it comes to an individual. Now, when it comes to these food items or groceries that we get in, I think it is nowhere proven at this point of time that groceries or newspaper for that matter is a potential fomite for transmission. So what I highlighted in one of the slides, I think we need not panic about that. Anything which has plastic, anything which is brought in with the plastic can be cleaned. A simple cleaning in a running water is more than enough. Vigorously scrubbing it off, soap and water has not found to be much beneficial at all. Obviously there is no RCT that we can do to find out whether this is beneficial or not. But I think common sense tells us that the virus cannot transmit to these fomites in a very efficient manner. Wash them in a running water more than enough. Clean the vegetables, which anyway is mandatory. Clean it off, and then as much possible avoid consuming raw food. Anything which is raw is potential carries the potential for transmission of infection, and that should be avoided. Clean them like you usually do is what I would suggest, because there are no clear-cut answers. There is no effective disinfectant for food or anything which carries food at this point of time. So simple cleaning, use of water is more than enough. But when it comes to clothing, like I said, I think dip it in Savlon or phenol for about half an hour or so, wash separately, and then sun dry them. That should be more than enough. And they won't act as fomites. And shoes should never enter the house and then go into the common area. You keep them outside overnight, they stay in. I think the chances of transmission is very less. So I think it's a matter of common sense more than any scientific principle which will prevent transmission of infection in these
Thank you
cases.
so much. Ravi, a question for you. You know that at some point, as we already said, let's accept the fact that we are going to land up with this infection. Uh, we are reading so much about the newspapers about the really bad aspects of when people land up in ICUs and on ventilators and stuff like that. But we don't hear much about what simple things you can do for yourself if you get infected. We're hearing all these bad symptoms that you can get, and it doesn't seem like it's just a common flu. It's not just little sniffles here and there. The way we hear the reports of those who have gone through it, it sounds pretty bad a disease, even for the people who have the milder or the moderate form. But I've not read much about or heard much about what can you do to mitigate your symptoms. What would you as a pulmonologist recommend? Simple things that we can do at home to make our symptoms more tolerable.
Well, I think the whole thing comes down to the nature of the disease, which will define what point you can put in appropriate interventions. Good news: the large cohorts, 80% of people will heal on their own. So that's the whole thing over there. So if you get something which is anything like a respiratory infection, we highlighted the fact that there's nothing specific. Just sit tight. You're not in the high risk category. You can either do things yourself, wait it out, use simple common sense measures such as symptomatic treatment, paracetamol, and so on. But if you get worse, you can always reach out. And all of us are healthcare professionals. We reach out to our colleagues. There's helplines for the lay people to reach out to. And then by and large, if you're still in the category of mild, so the government has categorized them into all sorts of mild to moderate to severe categories, you will still be asked to stay at home and ride it out. If your symptoms get worse, is when you seek healthcare, and the harbingers of rising fever, shortness of breath, and so on. So this is where we stand. What can you do once you get a symptom? You can just take symptomatic therapy, but there's nothing specific for COVID per se, which will prevent the acceleration from plain regular symptomatology to what requires hospitalization or critical care. That is where the treatment thresholds come in. The treatment thresholds are at this point stated only for moderate disease onwards. So all the treatments with hydroxychloroquine, azithromycin, which you hear about, are not for mild disease at this point, though have been used a lot. So in our country, people are popping them a lot even for mild disease, but not really recommended. So bottom line, watch it, watch the signs and symptoms, seek help as required. If anxiety is driving your particular thinking process, it's not a difficult thing to get people to talk to you, and watch it. Currently in India, we're not inundated with this category, but the UK and the US were. What did the UK do? They said, stayed at home, gave you a hotline and said, until you get symptoms of a concerning nature, you don't come into the hospital. They used to send teams home. If you were really in that category where they thought you're getting worse, they would take you into the hospital. So that is something we have to watch for and see. But the long and short of it is just do the regular stuff and seek help if any of the warning signs come. All the
So,
theories of vitamin C, lemon, and what else? There's so many things over there touted right now. Yoga, alternative science, nothing seems to be panning at being categorical or helpful. If at all it makes you calm, you can do it.
no, if you can share some OTCs that, there might be some lay people who have logged into onto this as well. And even we as orthopedic surgeons would like to know, what symptomatic treatment we could do. So give us a list of different things that we could do to mitigate some of our symptoms, because it's easy to say, just suffer it out. But I'm sure we want something to
Whatever
do
you've been
to
doing
make,
lifelong for viruses, what you do now.
we,
Basically,
we, we take antibiotics. We are that bad.
you don't need to take antibiotics at all. So azithromycin
Exactly.
is the only weak antibiotic which came somewhere out there. But otherwise, there's no role for any antibiotics unless it's a proper bacterial infection. So you'll be taking, if your nose is clogged, you'll take symptomatic treatment. If you have, allergic symptoms, you'll take antihistaminics, paracetamol for other things. Hydrate yourself well. The main thing is that physical distancing. If there's any small chance this is COVID, you at least should be in a position like to ask these questions appropriately to physically distance yourself and watch for worsening. 80% chance nothing is going to happen to you. That's the good statistics on the ground. Even if something happens, 15% of those are reaching hospitals, but they are not requiring higher level of healthcare. The 1 to 5% in the Chinese cohort, extending up to 10 to 12 in the Italian cohorts, are the ones who are going to require all the scary stuff, which is making us do these webinars and not meet face to face.
Okay, the other question we have for both of you guys is, it's been often said that people in that mild, moderate category seem to do very well for the first week or so, and then suddenly take a turn for the worse around the 7th or 10th day. What are the symptoms you should really look out for? You've got high fever, you've got cough, you're feeling miserable. What are those real symptoms you should look out for when I need to pick up my phone and call you, or call my local hospital and say, boss, should I turn myself in? Should I come into the hospital? What is that point? What is that symptom which is required for us to take hospital care?
So if I can just venture into that one, what's happening in India is very different from the rest of the world as of now. It's very clear. If you are getting mild symptoms, you will stay at home, or you can come up to one of these, contact these hotlines and get to one of these fever clinics, which are there abundantly there now in various cities and various states. If you get high fever, you're going to reach a hospital now. And if you reach a hospital with high fever in current times, somebody or the other will admit you and the test will get done because that is the ICMR approval criteria. So that is what is there at this point. So the only thing is when it reaches the stage of community transmission and healthcare cannot manage these people, is then that's when you're keeping even the high fevers at home. Currently, anything which is out of the ordinary will reach a hospital. Even the government system is equipped right now, get admitted, and most likely you end up getting the test.
Great. Vinay, do you want to add anything more to this? Is there anything that you feel when a symptom which is worrisome, where you should
So,
approach the hospital?
Sandeep, can I ask a question?
Yes, sure, Sandeep.
So, Ravindra, how far should one in the milder form of disease use pulse oximetry at home to look at oxygenation? Because that was one of the things which is being highlighted, that you get a
Yeah.
pulse ox, put it on your finger and see the saturation.
So it's a lovely question, and it comes down to two premises. That one, your your baseline pulse ox is normal. God help you. The second is that you don't have any other coexisting disease. Third is that you're a healthcare professional who has access to a pulse oximeter. Fourth is your pulse oximeter is actually working because you haven't used it in a long time, and you make sure it's working well. If that is the case and you see it, and if the thing is low, then the worrisome data which came from abroad is that if it is slightly low, are you one of those asymptomatic people with X-ray or CT scan findings who may be getting worse over time? And that is a subset no one has an answer for. We're not seeing a lot of that practically in India, but we don't have data on the ground. What they're doing abroad is if that is the situation which is slightly low, they'll make you do a walk test. You must have heard of the 6-minute walk test, which is simple.
Yeah,
You walk
or a
and
breath count.
yeah, and no 6-minute walk test. You're actually walking with the oximetry. If you desaturate when you're walking, it's one of the easiest, simplest, most practical tests to show that there is a lower respiratory involvement. You may get worse. You need to seek help, and that is a category who'll probably even get medicated with the hydroxychloroquines, azithromycins, and so on. So that is a very, a very intensive answer. It's not a common thing to go through, but if you have it on
Yeah,
this,
so people need not go berserk and start buying pulse ox.
no, it's pointless at this point.
Great, thank you so much. And I think one of the other questions is, now suppose I've had an exposure to a person with COVID. For example, I'm a healthcare worker, and by chance I find that the patient I've operated on turns out to be COVID positive. What's the right time that I should seek testing? Should I wait for symptoms to appear? Should I do it on day 1? Should I do it on day 3, day 5, day 7? What's the take on that?
If I can answer that, at this point of time, like I said, asymptomatic people, asymptomatic individuals, we are not sure what is the right time to test. So if you are exposed, now the current strategy is quarantine, stay away from your family members as much as possible and watch out for symptoms. Because the ICMR strategy does not involve testing asymptomatic healthcare workers. It only tests symptomatic healthcare workers. So till this testing strategy is liberalized, I don't think we can use that. That is number one. Second, let's say you have access to tests, your hospital has access to test, it has RT-PCR, and you somehow get through getting it tested. We are at no point now certain that what is the right time to test if you are asymptomatic. Like I said, the performance in asymptomatic individuals of this test is poorer than in symptomatic individuals. In symptomatic individuals with a good nasopharyngeal swab or a oropharyngeal swab, RT-PCR has a sensitivity to an extent of maximum 65 to 70%, whereas in asymptomatic, it may be hardly 30 to 40%. So doing a nasopharyngeal swab test, which is probably the easiest to access at that point of time, and getting a negative sample still does not rule out anything at all. So it is still wise to rely on the symptoms. Second, the average incubation period from the time of exposure to an infected person to you manifesting with symptoms is around 5 to 7 days. It has gone up to 14 days. In extreme situation, it has gone up to 28 days. But you can say it is anywhere between 7 to 14 days practically. If you do not get any symptoms during this period, one possibility is that you were exposed but were not infected. Two, you were exposed, got infected, were asymptomatic, and then you cleared the disease all by yourself. So don't have to wait for testing at all. So at this point of time, the most practical strategy is, unfortunately, wait for symptoms to set in. That then is when you can rely on the test, and then is when you can get tested. In asymptomatic individuals, testing has not been proven of any great benefit. It is not reliable at all.
Great, thank you so much. Sandeep and Dhiren, do you all have any questions?
Yeah, I
Yes,
just had one more question. Sorry, Dhiren bhai, you can go ahead first.
yeah, there are a lot of varieties of PPE are available in the market. Some are laminated, non-laminated. So if we have to select, which one we should select?
Right. So, I mean, what you need to look at is when you're using a PPE, like the gradation I showed, you need to design or decide on your PPE depending on where you're sitting. If you're in OPD, you don't need to use a full PPE. Now, for example, if your question is, I'm operating on a patient who strongly suspect or COVID positive, and I'm in the operation theater, you'll have to go in with a full kit where you have a fully covering gown, you have a goggle, you have an N95 mask at least, and the anesthetist should also wear a hood. Now, the simple rule about PPE is, till now, we didn't know much about PPE, its certification and all. PPEs have to be certified by a valid authority, something like an ISO or an ISI gradation. At this point of time, unfortunately, it is not going to happen at all. So the simple rule of thumb that you can follow is any PPE which is impervious, that is, it should be water resistant. Because if it is water resistant, that means it practically implies that you won't get drenched in any sort of secretions that come in, blood can't stain in, and also the respiratory particles can't enter in. So any PPE which covers you completely from top to bottom when you're operating and which is impervious, water resistant, is what is important. Also, what is most important, it's not just the PPE, it is the way you wear it. Before you start wearing a PPE, you should thoroughly go in and then start learning about donning and doffing. Your chance of getting infected is maximum at the doffing time, not at the operating time, not at donning time, but at doffing time. Because if you touch anything on the exterior, you don't use precautions well, you might still get infected. So it's not just PPE, you should know how to don, how to doff. And when it comes to the PPE quality, it should be an impervious one where no part of your skin should be exposed to the patient at all. So cover it well. So that is what is the simple rule that I can tell you.
The other part of it is, if I can add to this, is they've got all sorts of certifications. So ideally, you need either ICMR, there's a South Indian Society Circa or something, there is CE certifications, but those are quite expensive right now. The other thing is what's called GSM criteria, grams per square meter. So the full PP, which is the impervious one required to operate a possible COVID, is there should be at least 90 GSM. So if the fellow is not willing to give you all that, it's unlikely. And then you'll have to test also when it comes to you. If you throw water and it's going to go through, obviously it's not impervious. So N95, again, you require certification because we're going into N95 reuse protocols. The full PPE should be a 90 GSM at least, and if possible, certified. But then the whole thing is PPEs are going like the stock market at this point. They're varying the prices. They're doing all sorts of hanky-panky. Hopefully, this will come under quality and price control very soon so that we can get our work on the ground going.
Well, let's hold that thought. Both Ravi and Vinay, the question that is really a burning question for all of us is about the N95 masks. We know we're going to fall short of them. In fact, we're already short of them. What are the recommendations for reuse? We know we are reaching that point, and we already have reached that point where we are going to have to reuse our masks. What is the best way to reuse them? First of all, are they reusable? Secondly, if we have to, what's the best way to reuse them? What way can we disinfect them? What's the most reliable way that we can ensure that we can reuse those masks safely?
Till about last month, I think sadly, none of us had to wonder about or think about or scratch our head about reusing N95 mask at all. N95 was a one-off use and then throw it off. That's what we used to do. But now we are rethinking those strategies. The first question, yes, N95 masks are reusable if they can be disinfected in a proper way. Multiple strategies have been tried. The strategies which have consistently shown benefit are if you can pass the N95 through a good tolerable autoclaving system which does not damage its porosity, that is, it does not break, the elasticity does not go away. That is one of the best ways to disinfect your N95 mask, and that is what we are currently doing at Apollo. N95, if it is used for the day, we are just naming them with a marker. We're just putting in a dot saying yes, this has been used once. It is placed in a pouch which is autoclave safe, and it is autoclaved for a given duration. That is determined by a microbiology team and then the CSST team. And once that comes out, it is air dried for about 12 to 24 hours, and it is available for reuse on an alternate day. So each of the doctors or any staff who are working are given a pair of N95 and then every alternate day that is used. And with this strategy, various experiments, various trials have proven that you can use it for up to about 5 to 8 times, provided your N95 does not get soaked, your N95 does not get stained with blood or any other secretion, and your N95 does not break or there is a hole in it. If this doesn't happen with use and autoclaving, that is the best strategy to go forward. Second thing is there have been other things tried in US. I mean, there is a word about hydrogen peroxide fumes. There are a lot of hospitals which are going in for that, where they are placing N95s in a chamber wherein hydrogen peroxide fumes are generated. They pass through it and then they leave it on for quite some time, and then they are used the next day or on an alternate day. Ozone is one which is believed to be better than hydrogen peroxide, but ozone is known to break the integrity of N95 mask, but in a controlled manner, even that has been made use of. So at this point of time, reuse strategy has been successful only with good autoclaving, safe guarded autoclaving, hydrogen peroxide vapors, which most of us are not using in India, ozone, which some of us are trying in India. but autoclave seems to be the most beneficial and then useful method with which you can use the N95 or use it for about 5 to 8 times. So that is the strategy which we are using at this point of time.
So most of us don't have access in the hospitals to all of this stuff. Most who are actually going back to hospitals are mainly doing a outpatient clinic, and I don't think many hospitals are offering this to us. What's a home remedy to sterilize or disinfect these masks?
Okay.
So
So
what the
two
US,
things there.
I can ask you one question which came from our Texas friends. What they are doing is they're putting it in a paper bag. They finish the shift, they put it in a paper bag, and they come back next day to with a 24-hour hiatus. And after 5 days, it's going for this sort of sterilization, which he was saying. The second thing, there are industrial, there are some sort of N95, which is one of those with a filter. It's got two filters on either side, and that is goes on for a month, and the filter needs to be replaced. It was available on Amazon for a while till, of course, everything came to a lockdown. I've sent you a picture of that, Alric, on your media. So a lot of these strategies were there. So the US, who's already seen a level of life never done before, they are doing all this stuff. So practically paperback, sun, and all that. Anything else which Vinay suggests was also part of the thinking strategy at this point.
So if I can answer that, I mean, what has been done, I mean, what you suggested the Texas people are doing, again, not scientifically validated. I think they can refine it one step ahead. What you can do is, rather than putting it in a paper bag, if you can just sun dry it, I think that's the most suitable method. But anybody who's using N95 and thinking of reusing it, please do understand that if it is soaked or wet or soiled, no way you should be reusing it. Second, if there is any stain, anything of that sort or a break, please do not reuse it. At no point should you touch the outer surface of N95 at the end of the day. Learn how to use and remove N95. And if you can safely do that, and if you don't have access to any of the disinfection strategies that I spoke about, best is to sun dry them. This is summer, hoping that the sun lasts for all the while it would last. I think sun drying is probably the safest strategy. Covering it with any sort of paper, I don't think makes any difference at all. Wherein we are waiting for the virus to die out, allowing it for 3 to 5 days and allowing it to die out. What is known as, I think, keeping it out in the environment or in the sun probably accelerates the deceleration of replication of these viruses. So if you can sun dry for 24 hours, need not be outside, somewhere where the sunlight can enter in. That seems to be the safest strategy if you can't get access to any sort of autoclaving hydrogen peroxide or ozone sterilization. But make sure you do not touch the outer surface for that 24-hour period where you kept it for drying. No other strategy seems to be safe and effective. There was some call about wearing a surgical mask on top of N95 to prolong its life. I feel that probably at best can be called as an ill-term strategy. And no, it should not be made use of at all. It suffocates you more than anything else. It probably reduces the life of N95 because you sweat more. So just use it, remove it safely, keep it out in the sun for 24 hours for the virus to die out, and then reuse it till the integrity is maintained. That is what I would suggest as a safest and simplest strategy to reuse N95 masks.
Great. Thank you so much. Ravi, here's one existential question for you. We have stayed out of your way for the last 1 month. We have kept our ORs empty. We have kept beds ready for you guys. We are helping you as much as possible. When can we get back to doing some sort of stuff? When can we, we have to understand a lot of us are daily wage earners. A lot of us run nursing homes. A lot of us have staff that we have to employ. What do you feel? I know this is a very difficult question to answer. What do you feel as a pulmonologist and critical care specialist, and Vinay again as the infectious disease specialist, that we can reasonably go back to some degree of work? We understand that it's not going to be an all or none, and not going to jump back right away into work. When can we start phasing in with some degree of outpatient clinics, then go in with all the precautions that Vinay mentioned about, which are going to be really hard to do in a hospital, and especially in a little nursing home where people are not so careful about infection control. Uh, when can we go back to doing, I wouldn't say elective surgery, but even one of those expedient surgeries, or expedited surgeries as we call them. Elective surgeries are those where you can wait for months on end, but we have a lot of conditions in pediatric orthopedics where we need to expedite the process, not necessarily emergent or urgent, but within the next month at least. Give us some figure that you are thinking of. It may not be uh, absolutely evidence based. May a lot of it may come from your thought process. When do you think we can do this? Ravi first, and then Vinay.
It's a lovely question. Of course, your paramount, sacrifice in giving us your facilities is well appreciated. And we have been some sort of a COVID villains as this, everything stopped, all elective stuff stopped. And of course, in the end, when everyone realized that nothing can happen, it was a no-brainer. Now it comes down to two things. Clearly, let us admit that we definitely want everybody to get back to work. Everybody should get back to work. But then the whole challenge is the following over here, that what is the risk which you incur when you get back to work? So what is your community risk? So one of the guidelines or the initial directives coming out is that you should have relatively less or decelerating cases in a 14-day window. Now that's a tall order, but it's happening in at least half of the districts in India as per statistics coming up. The second is that despite all that, you have mechanisms in place to first of all decide about the importance of your surgery, because these are tough times. And you already put some words out there that you're thinking of either urgent or semi-urgent and that sort of stuff and so on, because you can't just wait. It's like chemotherapy and radiation and so on. The third is that can you ensure a certain amount of infectivity, prevention, that the patients who are infected are not operated, cross infection between parents provided, between patients provided to patient and patient to provider. So that will be the whole key of the whole thing, because we've never dealt with this level of infectivity before. We'll have to put in systems for that. That comes down to the crunch on two things: that what is the COVID infection protocols you put in, and the make or break is clearly acceptance of those protocols, a change of mindset, training to implement them, and that dreaded word PPE, because PPE appropriately utilized will allow this to happen. And of course, the most important thing which we repeat and reiterate is you cannot allow uninfected people to cohort with potentially infected people. So if all those principles can be put into place, all this will fall into place. Currently, as we speak, everyone is trying to say, Medanta starting, why are you not starting? Put a protocol into place. And everyone's coming out with guidelines which include a clinical review, a detailed clinical review, including contact with COVID and so on, and compliance with physical distancing and so on. Then they're trying to use an RT-PCR, which is challenging because private labs only will do it. ICMR people will not do it. The antibody test is not on the ground. We're still struggling with the fact that there have been these kits which are not reliable, which have hit the ground from China or something. So a combination of all these is what is ultimately the answer. And the fact is that you've done good enough community control. That stage will come. When is it going to come? None of us know. But we certainly know that semi-urgent and urgent should happen in a safe way. Like when I pointed out, the PPE trail, risk assessment of surgery, then completely trying to make safety criteria as much as possible and maintaining a PPE trail with the caveats of getting it, following it, training on it, and costing it. Right till the end will probably be the initial way to start. That is why I put those slides, Alric. When you say it's full change, it's a change of mindset, it's an adapted phenomena. And much as we have kept your, busy hands away from what you do the best, it is a graded way of getting back to work.
Great. Thank you, Ravi. Any comments from Vinay on that?
I can second that. I mean, that is what none of us are sure what would be the safe time to start operating, going in for elective procedures and all. And PPE and the availability of PPE, to what extent you can make use of, will decide how early you can start operating and how safely you can start operating. I think the issues come in if you are a standalone surgical center. It may be orthopedics, lab surgeries, or anything of that sort. At the end of the day, like I pointed in one of the slides, our personal experience has been that we probably have minimized the risk entry into the hospital by a robust screening system. What helps is having a medicine and medicine subspecialty. So that helps for a multi-specialty center. But when it comes to a standalone center, I think it is quite difficult. So there are a lot of things. What we are trying to devise ourselves as a medicine ID team and all is to try to get a risk score, under risk stratification score, wherein even non-medical people, in the sense non-medicine specialty people, can look at the risk score and try and find out as to what could be the safety level or risk level of this patient of infecting us. Depending on that risk score, we have not validated it. I think probably we'll try to do that by this week. If that works out, use all precaution, use N95s, use your PPE judiciously, and then maybe you can start operating on the semi-emergent and emergent cases rather than the elective ones. Elective ones, like you said, yes, they have to wait. Nothing worth risking your lives for, and easier said than done. But yes, I think I would say if the lockdown is eased, practically you need to wait for at least 2 weeks to gauge the situation, look at the rise of the cases, how briskly the case peaks, And depending on that, I think you can start planning. This is not the right time for us to answer because we are still in lockdown. I mean, what is shown, like what Dr. Mehta said, is just the tip of iceberg. If lockdown goes off and 14 days at a stretch or 21 days at a stretch, lockdown is not implemented, then is when we'll know the real situation. And then is when anybody can answer this question in a very safe and effective manner is what I think.
If I can add two lines more, is that people like us, we do this thing called bronchoscopy and intervention pulmonology. We are the death knell because we are the maximum aerosol possible. There is no way we can get back to work with what is going on right now, and our costing is too low to even look at this stuff. So we are ourselves struggling as a profession. But what I can think of is innovative stuff will come out. For example, you're talking corporate centers will figure out, right? Where they'll put teams. When I say you'll have tests coming on the ground, you can bill people and so on. But I think nursing homes will have to ultimately, maybe as unique solutions, get together, get one place COVID ready. That means you put all the precautions in that place. You try to get testing on the ground, which will come. You try to get PP in that place. You try to make that PP trail right from OT right to your wards to discharge and so on. And then get together in one area, operate in that place, pool your resources. It no longer can be my place and so on. It may be pooling minds, resources, and systems together to try and get something on the ground. Many unique solutions are required right now. No one can give us the answer. No society, no guidelines. They can only tell you safety, and most likely they'll wind up stopping you more than facilitating you. Facilitation of facilities will be by putting systems into place. We have also touted this COVID ready and COVID compatible centers. We're not saying call them with the hordes, but at least do enough to protect your cases so that you are comprehensively doing everything in that train to protect yourself, into taking help of specialists, and all of us are very happy to help in this sort of enterprise.
That's a really wonderful, I think, question answer session. I think we are almost done with time. In fact, we have exceeded our time, but we were really enjoying ourselves so much. And I'm sure a lot of people also have learned quite a bit, reinforced some of the thoughts they already had, as well as maybe clarified many of their doubts and queries. At least I know a lot of my doubts and queries have been answered. And I know there are many intangibles which will come out only over the next few months. But I think you all have really done a wonderful job. Is there anything else from Sandeep or Dhiren?
Yeah, can I ask one last question to both of them?
Sure.
After you have been positive and undergone the mild disease, are you immune for life? What is the chance of getting reinfected, and are you going to shed it even further then? That's the last question, I think. Does it guarantee you a lifelong immunity, getting the disease?
If I can go first, if you have to, you should be very lucky if that thought comes true. At this point, since it's just 3 months, it's hit us, none of us are sure at this point of time. If it behaves like how influenza does or H1N1 does, then no, the immunity will not be lifelong. You are at risk of getting reinfected. And the only way you can prevent severe disease would be to have a vaccine in place, which might happen at some point of time. We don't know when, maybe a year later or so. You will be exposed to the infection at some point of time, and probably the immunity will prevent severe disease. That's all. But I don't think there should be a chance of lifelong immunity. It has hardly happened in any of the diseases. Very few diseases give you lifelong immunity, something like a chicken pox or a measles. This is unlike that. This is more like influenza. So the belief is that it will come back, but may not sting you that much. And hopefully it does that.
Okay.
Ravi, any words of wisdom finally to sort of wrap up this whole discussion?
No, so I think that what's happening is the cascading effect of the initial reaction. Lockdown, stop all work, look at what's going on, has been something which has been unfathomable and unimaginable. We all need to sit and figure out, this is what is there, this is what I can do. How can we all get together, help each other? Out of the box solutions will have to come, because no one is out here to dole solutions out to us with, just do what you were doing before. It's never going to be business as usual. It'll be coming out with innovative and practical and recommended solutions to try and keep our patients safe, so that this infection cycle breaks, and ultimately till either we ride out the virus, we become used to it, we get immune to it, we have drugs on the ground or vaccines coming.
Great.
Right.
So thank you so much, both Ravi and Vinay. You all have really taken time out of your very busy. I know you all are really inundated with work, and you all are the true frontline warriors. I have no hesitation in saying that. And I will just wind up by saying that from Posi, we are really very grateful to both of you for sharing your thoughts, your wisdom, your experience with us. And our prayers and good wishes are always going to be with you all, because you all are the guys who are really out there in the front, taking care of all of us, our patients, our relatives, and us as well. Because at some point, when this strikes closer to home, we will need the expertise of all of you guys. So may God bless your hands and your minds and your thoughts. And thank you so much again for sharing your time with us. Thanks, guys.
Thank you.
Thank you. Thank you. Thank you very much.
Thanks.
Neeraj, I think we can sign.